Dr. Jean B. Nachega is an infectious disease internist, epidemiologist, and a professor extraordinary of medicine at Stellenbosch University Faculty of Medicine and Health Sciences in South Africa. He is also a tenured associate professor of medicine, infectious diseases, microbiology, and epidemiology at the University of Pittsburgh Graduate School of Public Health, as well as an adjunct associate professor of epidemiology and international health at Johns Hopkins Bloomberg School of Public Health. He has over 30 years experience in teaching, designing, and implementing HIV/AIDS, tuberculosis studies and programs funded by NIH and the Fogarty International Center, the Wellcome Trust, PEPFAR, and the EDCTP. He authored over 200 peer-reviewed publications, including in such renowned journals as The Lancet, the New England Journal of Medicine, JAMA, Clinical Infectious Diseases, and Annals of Internal Medicine. Dr. Ngacha, the floor is yours.
Hi, everyone. Let me first by thanking the organizing committee for giving me the opportunity to talk at the INTEREST meeting. This is my first talk at this meeting, and I'm so excited and honored to be here. This is the roadmap of what I'm gonna talk about, just rough global epidemiology of HIV and COVID, the effect of HIV on COVID, the effect of COVID on HIV, both treatment and prevention, how we can optimize evidence-based differentiated service delivery intervention in COVID era, the one we learned from HIV, how we can scale up COVID vaccination in Africa, also lesson from HIV pandemic, and finish with some concluding thoughts. The epidemiology of both pandemic is quite interesting. As you can see, the epicenter of HIV is in sub-Saharan Africa, where about 70% of people living with HIV are, with a total of 38 million at the end of 2019, and the cumulative deaths so far of 37 million since the beginning of the pandemic. In contrast, COVID, as of May 2021, a total of 165 million and about 3 million deaths since the beginning of the pandemic alone. And again, interestingly, in contrast with HIV, the epicenter is not in Africa. The epicenter has been in America, in Brazil, in India, and there have been some really, it's been puzzling to understand why Africa has been spared. That's a separate talk by its own. But as if we don't know how this is going to evaluate if there is a delay in vaccine coverage. But the epidemiologies of both pandemic are quite interesting. So the question is there any effect of HIV on COVID? This has been also, a question that the HIV community has been looked at. And there is several study. I have no time to go through all of them. I just selected the major one, the bigger one from Spain, US, South Africa, and the recent WHO Global Clinical Platform study. The first one from Spain, published in the Annals, about 70,000 people with HIV on antiretrovirals, so quite big study. HIV did not increase susceptibility of SARS-CoV-2 and did not increase outcome severity of COVID. Of interest, a patient receiving tenofovir, but not TAF, had better outcome. The second study, this time in US, about 3,000 people with HIV, similar rate of COVID diagnosis to those without HIV, but there was higher rate of hospitalization and higher mortality, people with HIV. And also of interest here, folks with CD4 below 200 had higher mortality rate. And then going to South Africa, this is in the public health sector. Andrew Bull published in CID showing that the standard mortality ratio for COVID death in folks with HIV was about 2 times higher. And interestingly, here also, tenofovir, folks on tenofovir seems to do better. And folks with CD4 below 200 had higher mortality. And then, as I mentioned, this is the global clinical platform, WHO massive study presented at EIS by Silvia Bertognolo. This is anonymized patient-level clinical data, about 168 HIV patients from 24 countries, quite very well representative globally. Just to go to the results, among people with HIV, they did confirm the traditional comorbidity of higher elderly, male sex, diabetes, hypertension, independently associated with COVID. But what was really important here, they really did sit with much conviction the association of HIV with COVID severity. As you can see, relatively narrow confidence interval, very narrow confidence interval, but also in hospital mortality, again, a very narrow confidence interval. So next question also been puzzling us is what the effect of COVID on people living with HIV. So this is really a no-brainer. And this has been exemplified in the New York Times. The pandemic is hiding victim, sick or dying, but not from the virus. So actually, as you may have experienced from friend, colleague in the community, this pandemic has been have indirect effect on morbidity and mortality by delaying HIV treatment and prevention services and increasing loneliness, substance abuse, and depression, not only in the general population, but obviously in HIV, who are already vulnerable. And this is just a selected list of indirect effects. The list is quite long, but we don't have time to go through all of it. And the modeler, this is UNAIDS modeler, they look at what the potential cost of interruption of HIV services in Africa. And as they calculated and estimated total AIDS-related death with a 6-month interruption of heart of about 1 million. So this is the part, I think, where we can try to make a difference. What can we do? And there is almost 4 pillars here, trying to look at susceptibility, improve testing, try to impact prevention and treatment. So all are evidence-based intervention proven, through robust study design, mostly randomized clinical trial. The impact of counseling, economic, social services, substance abuse, mental health on decreasing susceptibility of both HIV, but that can be adapted for COVID. Testing, we know about testing either at emergency setting, testing in community, home by home. So those interventions can also make a difference in the COVID era. Prevention and treatment, this is also differentiated service delivery model where you bring the services to the patient to prevent them to have in-person consultation at the clinic. We can really scale up and improve, optimize their implementation. And this includes, multi-month antiretroviral supply or PrEP supply, phone visit, telemedicine, SMS adherence support, improve quality and access of oxygen and high ICU scope and quality. This is mostly for COVID patient. So this is just the next 2 slides show you some of those evidence-based interventions. This is a 12-month cluster randomized trial in Lesotho of 3 versus 6 month dispensing of antiretroviral among stable HIV adults. And as you can see, this is a non-inferiority trial showing there was no difference in retention or virological suppression for stable HIV patients receiving multi-month dispensing antiretroviral with community-based differentiated model when compared to facility-based standard of care model. And this from my own group, we presented at CROI in 2020. So this is in South Africa private sector, health sector. We demonstrated that positive impact on adherence and virology outcome, dispensing of antiretroviral with home delivery compared to facility refill. So those interventions have been proven effective and can be optimized. So before closing, let me also bring your attention to our perspective my colleague and I wrote in the New England Journal on how we can learn from the HIV pandemic about our recent effort in the CDC Africa and globally COVAX scaling COVID vaccine in Africa. And this range from health infrastructure, key population at risk to target, prevention and treatment reluctance, hesitancy, and stigma, communication, and obviously prevention and treatment in vulnerable group like pregnant and children. So there is some similarity. While those pandemics are different, there is some similarity in the approach we took for HIV that can be shared. And I have no time to go in detail, but this is open access at New England Journal. You can go and read from it. So to conclude, people with HIV often present with the same clinical sign and symptom of COVID as people without HIV, and the vast majority recover from COVID. Also, people with HIV who are on antiretroviral and have normal CD4 counts, the clinical outcome is likely more dependent on factors that to affect risk of in COVID, including age and comorbidity. However, HIV-infected patient not on antiretroviral or with unsuppressed viral load or have low CD4, I think the data presented here convince you that they may be at excess risk of poor outcome, and we should definitely try to optimize those by using those evidence-based intervention. Lesson learned from HIV pandemic: consideration about health infrastructure, local epidemiology, responsiveness to local concern and belief are critical to end the COVID pandemic, not only in Africa, but globally. So let me stop here by acknowledging my collaborator in South Africa at University of Pittsburgh and at Johns Hopkins, and most important, also important, my founder, mostly at NIH. And also I acknowledge a colleague who contributed slide to my talk. Thank you very much.
Thank you, Jean. I now introduce our next speaker. Dr. Naradzo Mavis Mogodi is a clinical pathologist with over 10 years of experience conducting HIV prevention trials amongst women of reproductive age in Africa. She is a deputy editor of the Journal of the International AIDS Society and associate editor in Frontiers in Global Health, Reproductive Health, HIV, and STIs. As a lead investigator at the University of Zimbabwe Clinical Trials Research Center, she has overseen several trials assessing the acceptability, safety, and effectiveness of HIV prevention for African women, including oral PrEP, vaginal microbicides, the dapivirine vaginal ring, long-acting injectable PrEP, and broadly neutralizing antibodies. She is a protocol chair for an HVTN/HPTN study called AMP, Antibody-Mediated Prevention, and of the MTN-25 HOPE study. Naradzo is the international principal investigator on the HPTN Executive Committee. She's also a scientific reviewer for the Medical Research Council of Zimbabwe and has served as a technical advisor for the Zimbabwe Population-Based Impact Assessment, ZAMFIA study. Please, Dr. Mogodi, the floor is yours.
Hello, everyone. Thank you for joining this session, and I would like to thank the conference organizers for inviting me to speak on new HIV prevention methods for women. I have no conflict of interest to disclose. This is my presentation outline, but before I go on to my presentation, I will start by looking back at the Interest Conference of May 2016. The underpinning theme of the 2016 Interest Conference, held in May of 2016, was ending AIDS as a public health threat by 2030, in line with the worldwide goal set by the United Nations in 2016. The use of both antiretroviral therapy as treatment for patients with HIV infection and as pre-exposure prophylaxis for those at risk for getting HIV has become the major combination approach for slowing the spread of HIV in populations and countries hardest hit by the virus. Despite the availability of highly effective strategies for the prevention of HIV, the number of new HIV infections worldwide remains unacceptably high. The current oral PrEP regimen has got some limitations, primarily because of suboptimal uptake and adherence challenges amongst at-risk persons. And the main reasons cited for low uptake or discontinuation or poor adherence have been side effects, burdensome regimen, stigma, and pill size. So we need to develop a safe and effective and acceptable product that can be successfully used to reduce HIV transmission. So there's need for discrete products that users can control and use on their own terms. In the next 5 years, we anticipate that a variety of options for both PrEP and multipurpose prevention technologies will be available. And these will form a method mix better tailored for prevention options to meet each person's individual needs. We know that women particularly, they need multiple prevention options that make sense for their lives throughout the entire reproductive lifespan. They need on-demand, daily, monthly, or even longer options, non-systemic and systemic options. So in an effort to increase or to expand rather the PrEP method mix, the dapivirine vaginal ring is in the registration process in multiple countries. So what is the dapivirine vaginal ring? This is a small, flexible silicone ring which was developed by the International Partnership for Microbicides, and it slowly releases dapivirine ring over a period of time. This is the first ever long-acting woman-initiated HIV prevention method. So a review and analysis of the dapivirine vaginal ring trials has demonstrated that the ring is effective in reducing the risk of acquiring HIV. It is safe. Yes, and also 2 open label extension studies showed that there's increased efficacy, there's increased adherence, and increased retention in open label extension trials compared to the randomized clinical trials. The ring acts locally, so systemic absorption is low and toxicity is also less when the ring is used. And research has shown that the values and preferences and user preferences indicate the ring is highly acceptable. So this slide summarizes the overarching regulatory pathways for ring approval. Of note is that the ring received a WHO pre-qualification in November 2020, which shows that the ring meets global standards for quality, safety, and efficacy. And this will help countries in terms of decision once the ring is registered in many countries. I'm happy to mention that Zimbabwe was the first country to register the ring. This slide shows the next generation intravaginal rings, extended duration rings, multipurpose rings. And also this slide shows tenofovir-based and tenofovir levonorgestrel-based rings, which are currently being assessed for use as MPTs. So the ring prevention methods with even modest efficacy, they can have a meaningful impact as part of a comprehensive strategy that could avert millions of HIV infections over time. So the ring really would prevent infections among women that would otherwise not be averted by any other method. So the ring, yes, has favorable safety profiles and offers protection against HIV. This chart really, it provides a comparative overview of current and future PrEP methods, including long-acting injectable cabotegravir. Not shown on this chart is islatravir, FTAF, and lenacapavir, which I'll talk about. But as we continue looking at filling the gap, we must not only consider the product, but we need to look at the frequency, at the site of action, and the role of male partner in its use. So coming to long-acting injectable cabotegravir, in 2020, two studies, HPTN-083 and HPTN-084, demonstrated that long-acting CAB injectable is superior to daily oral Truvada for HIV PrEP. There was a 66% reduction and an 88% reduction in HIV incidence in HPTN-083 and HPTN-084 respectively. So both oral PrEP and CAB long-acting were safe and effective in these two trials. Already under consideration is a dual prevention pill, which is a co-formulated single tablet of oral PrEP with combined oral contraceptive pill. There's a coalition, the DPP project, which is looking at the dual prevention pill, and it's mainly working in Kenya, Zimbabwe, and South Africa. At the bottom of my slide, you can see the timeline, the anticipated timelines of the DPP. Here, I've just summarized some client perspectives, our preliminary insights from the DPP acceptability studies that we conducted in South Africa and Zimbabwe. We can see that the end users see the DPP as empowering adolescent girls and young women, and also it's less burdensome taking two pills and results in fewer clinic visits. But we as researchers and as product developers, we must look at the disadvantages listed here and we must address them if the DPP is going to be successful. Coming to small molecules, islatravir is a first-in-class nucleoside reverse transcriptase translocation inhibitor with multiple mechanisms of action. And this could be a transformative PrEP product with many advantages. It's highly potent. It has a high barrier to resistance, and it is unlikely to be a victim or a perpetrator of drug-drug interactions. To the left of my slide, you can see the study design of IMpower-022, which is a study which is assessing the use of long-acting monthly oral islatravir compared to Truvada. And this is being spearheaded by MSD with US and sub-Saharan African partners. Another interesting molecule is FTAF, which is more potent than TDF in HIV treatment studies, and TAF has demonstrated higher antiviral activity in target tissues and has less toxicity in many tissues, especially kidney and bone, as compared to TDF. Another small molecule is lenacapavir, which is a potential first-in-class small molecule HIV capsid inhibitor, which has exceptional potency against HIV-2 and all major HIV-1 subtypes. Gilead is spearheading the women's HIV prevention study, which is evaluating the use of long-acting lenacapavir given subcutaneously every 6 months. And it is also looking at Descovy and Truvada for PrEP. The AMP studies showed that a broadly neutralizing antibody can prevent HIV. We now know that VRC01 administered at 8 weekly intervals over 20 months reduces acquisition of HIV to strains that are sensitive to VRC01. From the AMP studies, we also learned that some of the characteristics of an antibody which are required to provide lasting prevention. And we also learned of neutralizing tests that can help predict an antibody's ability to prevent HIV. But like antiretroviral therapy, we know that combinations of monoclonal antibodies may reduce the likelihood of viral escape and increase neutralization breadth. So to the right of my slide, you can see that combining broadly neutralizing antibodies broaden neutralization. So a lot of work already has started on broadly neutralizing antibody combinations, as well as the use of tri-specific broadly neutralization antibodies. So the years ahead in HIV prevention research are highly, highly exciting. As you can see on this slide, there are many products which are being shown, and we can see the time to market. When do we anticipate that they will be available to an African woman like me? So this shows the vaginal ring long-acting injectables, the DPP, and oral PrEP that I've already talked about. So in summary, we know that daily regimen for HIV prevention remains a huge barrier to adherence. And these novel products are a potential game changer and may result in expansion of HIV prevention package for cisgender women in Africa and globally. But adherence still matters. Access is critical. We need safety data in special populations. And it is all about choice and options. For us to achieve this, we need a supportive organizational and policy environment to allow rigorous and timely scale-up of delivery interventions that work. So my presentation wouldn't be complete without discussing the impact of COVID-19 on HIV prevention. Yes, the impact on COVID-19 has been very significant on the fight against HIV. Though the number of HIV-infected people receiving antiretroviral therapy has continued to decrease, the declines in prevention services are alarming if we compare to 2019. So these disruptions are resulting from COVID-19. They have resulted in the people at greatest risk of HIV infection having less access to the information and the tools they need to protect themselves. And if this continues, after so many years of hard-fought gain, it would really, really be a tragedy to see the new HIV infections on the rise again. On this note, I would like to thank you for listening. And I, on behalf of the University of Zimbabwe Clinical Trials Research Center, would really like to acknowledge or fondly remember Professor James Hakim, who passed on 29th of January 2021 due to COVID-19 related complications. May his soul rest in eternal peace.